Hi, this is Julie Lubinsky. I am a manager for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to this month's Chatting Live with Nurse Linda. I'll tell you a little bit about her. She has been a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 20. She's also the moderator of our Ask a Nurse discussion in our online paralysis community, where she focuses on contributing functional advice, providing the how-to on integrating various healthcare improvements into daily life, and answering your questions. And we're lucky enough to have her live once a month here with us. So I will now turn it over to Linda. Hi, Linda.
Hi, and good afternoon, and welcome everyone. It's such a nice day outside today. I'm happy that you've taken the time to listen to the webinar today. We kind of got a little bonus in our weather, which is rather nice, kind of like a little gift that we're given, that we can get out, move about without putting on heavy coats and dealing with bad weather, so it's kind of a little bonus. This month I've been blogging about the autonomic nervous system. That's really getting a lot of buzz in the paralysis community these days because it's something that people have known about, but the effects of the autonomic nervous system are becoming much more apparent and much more aware to scientists, medical professionals, researchers. So they're really taking an in-depth look at this. It's been picking up some steam for quite a while. So in the nervous system, in your body, you have generally a couple of different parts. You have basically the brain and the spinal cord, which is the central nervous system, but then all the nerves that are outside of the brain and spinal cord are your peripheral nervous system. So these are managed by a couple of different systems, and one is the autonomic nervous system, or the ANS as it's referred to. And so the autonomic nervous system consists also of a couple of parts. The autonomic nervous system is that part of your nervous system that just runs by itself. I often call it the autonomic or the automatic nervous system, because the autonomic nervous system controls all those actions of your body that happen without you thinking about it. So a good one to think about is your heart beating. And you don't think about your heart beating. You can't control it. You can't make it go faster or slower just by thinking about it. Your heart just beats because the autonomic nervous system is automatically telling it to do that, so you don't have to think about it. Another part that's easy to think about is breathing. You just breathe. Even while you're sleeping, you're breathing. And so you don't have to stop and think, take a breath in, take a breath out. The interesting thing about breathing is you can override the autonomic nervous system and take a gulp of air, take it in a deep breath when you're doing your deep breathing exercises and slowly release it. So you can override that, but you're going to breathe no matter what you do, as opposed to other body functions, like if you're reaching for your pen, your mind has to think about coordinating your arm to reach out, take your fingers, grab the pen, and then do what you're going to do with the pen. So that's more under your voluntary control, because the pen can be there and you're not automatically going to reach for it. You're only going to reach for it if you want it, if you're going to use it, if you're doing something with it. Now, for the voluntary control, you don't have to necessarily think about reaching to get the pen, but your body's been trained, and as an infant and you went through development, you learn to coordinate the functions of your body so that you can do things on command. But the automatic nervous system is one that is taking such high precedence because there's so many issues that are connected with it. So if you think about the autonomic nervous system, it's much like other parts of your body in that there's a mechanism to make it go faster, there's a mechanism to make it go slower. So when you think about your muscles, which are not under the autonomic nervous system, if you want to pull your arm towards your body, that's one set of muscles. But if you want to push your arm away from your body, that's a separate set of muscles. So your body's kind of built on this dual system. The autonomic nervous system is sort of like that. It's a little bit different, but it's based on a dual system. In the one control of the system of the autonomic is the parasympathetic. And I know these are kind of crazy words because we think of sympathy and sympathetic, but that's emotions. This is nervous control. So they're kind of like crazy words that are attached to some of these activities. But the parasympathetic is a part of the autonomic nervous system that they give it the nickname of rest and digest. So the parasympathetic nervous system is in action when you're just sitting, when you're sleeping, when you're not really involved in any kind of particular activity. The parasympathetic just keeps you going at an even pace. It just keeps everything in rhythm. It just controls by just going, and its pace is established, and it just goes and does what it needs to do. Hence, they call it the rest and digest. It's just going to keep things going at a low level, just keep things moving along in your body. Now, the sympathetic nervous system is the opposite of the parasympathetic. So these are the two parts of the autonomic, the parasympathetic and the sympathetic, which I know are crazy words. But the sympathetic is that part of your body which is activated. If you think about the fight or flight syndrome, this gets your body sped up. So if you feel like you're threatened in some way or you're doing some kind of activity that's going to require a little more effort, the sympathetic nervous system will get that autonomic nervous system going, get it functioning a little bit faster, get it so you can meet the challenges ahead. So we don't often think about things like sitting up as being a challenge. That's not a threat to ourselves. But if you go through the process of sitting up, what happens is you're laying down, so that parasympathetic is keeping everything going at a nice even pace. But the challenge of sitting up requires you to change pressures in your body. So your feet are going down. Perhaps if you've been laying down, your feet are now over the side of the bed because you're in the process of sitting up. And the blood has to pump a little bit harder to get up to your head because you're working against gravity, because now your head is up instead of your body being completely flat. So the sympathetic nervous system is working. It's working all along. As you change position, it's working. But since you have this challenge to your body of changing positions and this complication of sitting up, the sympathetic nervous system will come into play, and it'll constrict your vessels so that your vessels in your extremities become smaller so that blood can pulse through your vessels in a stronger pace more quickly, and so that blood will be change from being dispersed throughout your body to having more pressure going up into your brain so that you get that oomph that you need so you don't get dizzy. And so that's what happens. And so the sympathetic nervous system is activating itself. But when you get regulated and now you're sitting up, the sympathetic nervous system will back down, and the parasympathetic just keeps going with its usual pace of keeping things moving. It's adjusted now to the new demands of your body. And so the blood, as long as you're upright and sitting upright, the blood has adjusted so that you'll get more blood to your brain where it needs to have a little bit more effort to squirt it up there through your vessels and through by your heart pumping, so that your brain has enough blood to function as how it needs. If you think about when you were first injured and you were in the hospital and maybe you had a lot of dizziness at first, it was probably because the sympathetic nervous system was not being activated to meet this challenge of sitting up. So if you had orthostatic hypotension, where your blood pressure would drop when you would sit up, that's what was happening, was in this automatic or autonomic nervous system, the sympathetic nervous system wasn't engaging enough. On the other hand, if you are, and eventually you can do techniques to help overcome these blood pressure issues, and eventually your body learns to accommodate. Sometimes you just need to get up slower. Some people who have cardiac problems and take a lot of blood pressure medications, sometimes they get dizzy if they stand up too quickly, and they can accommodate this but just by adjusting more slowly into getting into the sitting position. On the other hand, the opposite of that is autonomic dysreflexia, which a lot of individuals have, which is the overreaction of the sympathetic nervous system, and that it won't release itself to slow down. So if your catheter gets kinked or your bladder gets overfull, you get a bowel impaction, or if you even get a pressure ulcer or some kind of irritation to your body below the level of your spinal cord injury, if you have autonomic dysreflexia, the sympathetic nervous system speeds up. That's why you get that fast heartbeat, your blood pressure's going up, you get the headache because there's too much blood now in your head. And so then autonomic dysreflexia occurs. So making sure that we don't activate that sympathetic nervous system inappropriately can be a hard task to master when your body is kind of a little bit out of balance with these two systems. So there's a lot of other things that the autonomic nervous system controls. If you think about your bladder, since we were talking about the bladder, if you think about the bladder, what happens is that urine is being made by the kidneys. That's automatic. It's going to happen. The kidneys drain through the ureters into the bladder where the urine is stored. The bladder has a special muscle in it, so as the bladder stretches, you get these little contractions that you might not even notice. This happens to everyone. This is the process of the way it works. And when the contractions of the bladder get strong enough is when the bladder's starting to get full. And then the brain reads that message and says, my bladder's getting full, so I better go find an appropriate place to empty it. Now, emptying the bladder is on your own volition. If you don't have any kind of injury to your spinal cord, you just go into the bathroom and you toilet. So you can see how this is connected to the autonomic nervous system because your kidneys are going to automatically make that urine. You don't feel it in the kidneys because it's not stored there. It's immediately eliminated through the ureters down into the bladder. And as that bladder stretches, as it fills with urine, sometimes the autonomic nervous system says, hey, wait a minute, something's wrong. It can't receive that message quite correctly that the bladder's being filled, so it starts doing something else. And what it does is that sympathetic nervous system gets kind of in a panic almost, and it just keeps building and building, so you get the autonomic dysreflexia, the headache, and the high blood pressure, and those kind of things. So sometimes you have the sympathetic system that doesn't get activated, as in orthostatic hypotension, and sometimes you get it overactivated, which results in the autonomic dysreflexia. So the bladder is one, the bowel is another. It works in a similar process as the bladder in that your bowel is moving waste material through the bowel, getting all the nutrients and digesting the food through the bowel. And so it is collecting there in the rectum right before it's ready to go out. When your rectum gets full, again, those rhythmic contraction messages from the lower bowel are sent to your brain that would say, I need to use the toilet to evacuate my bowels, and you would go find an appropriate place to do that. However, if you have an injury to your spine or an injury in the autonomic nervous system, you might not recognize that full bladder pressure, and so you will get symptoms in other ways, which can result, again, in autonomic dysreflexia. As food goes in, before it gets to the bowel while you're eating and you're taking in food, sometimes for people it feels like that they're just full all the time, that the food's just sitting there and not not moving along. This again is could be related to a problem in the autonomic nervous system, because digestion works a lot by automatically the food is moving through the body. Once you chew your food and swallow it, the body just takes care of moving it along through the bowel. What goes in through your mouth is going to come out the other end. So if you're feeling that full feeling all the time in your stomach, it could be that the autonomic nervous system isn't working in that sympathetic overdrive. So your stomach is sitting there. The parasympathetic nervous system is resting and digesting. It's slowly moving the food along. But as you take in more food and your stomach stretches and gets full, the sympathetic nervous system will say, come on, gut, you need to get moving this food along. We need to digest it. We need to empty it out of the stomach. And sometimes that doesn't happen because the sympathetic nervous system is just not engaging. So that can be a problem for people, especially people who are not moving around a lot, because the gut works by automatically processing the food, but also when you're moving, the activity of the gut will speed up. So we know that when people are walking around, when they're exercising, that their stomach and their bowel function is quicker than when they're just sitting. That's why they say, oh, don't eat a large meal before you go to bed at night. It just sits in your stomach because you're resting and you're not moving around. So the parasympathetic is working as opposed to the sympathetic nervous system that says, let's get this food moving along. Let's get this gut emptied. So if you feel like you're having that constant full feeling, it's probably a combination of issues with mobility, in which you can do range of motion exercises. Even if you or someone is moving your legs or moving your abdomen, even if you're doing your wheelchair push-ups or stretching, that's going to help signal those muscles in your body to get things moving along. But it's also going to signal your autonomic nervous system to get moving and to get that food moving along to help you empty out through your stomach. We know that one of the problems after paralysis is a slow-moving gut, and getting that bowel to evacuate sometimes can be a real challenge. Things tend to slow down because the parasympathetic is not engaging as heavily and quickly as perhaps it needs to be. And so stomach not emptying is a real problem for a lot of people. They just feel full all the time. You're not burning as many calories. You don't need as many calories. So just movement is really the best thing. Now there's a lot of things that you can take in to help speed up your bowels. Laxatives, which we always tell people to avoid, general cathartic laxatives that just affect those nerve fiber endings in your gut and just zoom, empty it out right away. So you want to use natural methods such as drinking more fluids, which helps push the waste material along in your bowel, and then also doing some movement. But sometimes you will feel that full feeling in your stomach, and if you do some stretching exercise, move around that abdomen a little bit, even doing some massage around your belly will help kind of stimulate to move the bowel contents along. There are other things that are controlled by the autonomic nervous system, your blood pressure. There are some people who say, I can control my blood pressure. Well, you can't really control your blood pressure. Now, if you hold your breath or you strain, that's going to cause effects in your blood pressure, but it's only temporary. So blood pressure is really controlled from the autonomic, as well as the temperature of your body. So we make heat in our body through a couple of ways, the primary way being through the autonomic nervous system. Again, the parasympathetic nervous system keeps our body temperature going at a nice even keel. Sometimes when we have, again, that threat to our body, if we have an infection, the sympathetic nervous system will recognize that infection and will help speed things up in the body. So you can get a little bit, if you have an infection, you can get a higher blood pressure, you can get a higher heart rate. You'll notice that if you have a cut on your skin, you'll see redness go to that area. It gets even more red if it's infected because you have that blood that's circulating there trying to take out the bacteria from that particular place. So any of these things can affect that increase in the sympathetic nervous system, and if that doesn't then relax after the threat is over, then you can tend to go into autonomic dysreflexia. So these are many of the reasons why people are looking at the autonomic nervous system as being a big factor in predicting the outcome of complications and secondary problems due to your spinal cord injury. Because if that sympathetic nervous system does not engage, or if it cannot disengage, people tend to have more problems with all kinds of body functions. Their heart rate is more challenged. If you have secretions, the parasympathetic nervous system keeps the secretions in your bronchial tubes, in your lungs, keeps them at a nice even pace. But if there's a challenge with some kind of infection or there's some mucus in there, that sympathetic will increase the secretion, so you have a lot more to get rid of. So it all comes down to this, it all comes down to this autonomic nervous system. So people who tend to do better with after paralysis are people who don't seem to have the complications of the autonomic system. People who seem to have more complications have more problems with the autonomic nervous system. Now, what this all means to you and how you can affect this to keep yourself healthy is if you notice that you're having more problems with your autonomic nervous system, to try to do all the things that you need to do to keep yourself healthy. So drinking more, exercising more, if you need stockings, a compression hose, or binders, or whatever you need to try to go ahead and use those, as long as you're having some kinds of issues either with blood pressure or the autonomic dysreflexia, to keep things in control as much as you can for as long as you can. Generally, we say that people about T4 or above have problems with AD. Or at T6 and above have a lot of problems. We know that there is a nerve bundle at T4, and that's why people who have problems from T6 and above tend to have more problems with autonomic dysreflexia because of this nerve bundle. There's a bunch of nerves right at T4 that are packed real tightly together, and so those messages sometimes get transmitted incorrectly through that spot. But we also know that individuals who have injuries as low as T10 sometimes have problems with autonomic dysreflexia, and that is because not everybody's body is exactly like everybody else's. So you might have an injury that's at T10 and you think, oh good, I'm clear of the autonomic dysreflexia, but it might be that your nerves are a little bit lower, or maybe your injury has affected a little bit lower. So none of these are like cut and dried kind of rules. So I wanted to start a little bit about that because this is such a huge thing that's going on right now, and it seems like right now that once researchers get more information about the autonomic nervous system, the more that they'll be able to guide treatments and therapies. So it's kind of a wonderful thing that they're working on. Yes, I wish they had all this information years ago, but they're just starting to figure it out now. The body is a really mystical, complicated, and individualized system. So what works for me might not work exactly for you. So it's very hard to put all of this information together, but stay tuned because we're going to be hearing more and more about that as time goes by. So we have some questions on the chat board here, and we'll just start working down through them. Now, if you have any questions, if you're listening in and you would like to talk live, you can certainly do that. or otherwise we'll just continue through the chat board. So the first question we have here is, how long does the injury have to be before they consider it permanent? I'm at the 2-year mark and still unable to walk without assistance. Well, first of all, let's look at terminology. In today's world, spinal cord injury is not really considered a permanent situation. We now know that there's a thing in your nervous system called neuroplasticity, and your nervous system is trying to heal itself, and it will continue to do so as long as you are alive. So it's never like end game. It's an interesting, this neuroplasticity is an interesting thing because it used to be, and certainly when I got out of school and for years and years and years, people who had a spinal cord injury, we were taught, well, that's it. That's the way it's going to be. The nervous system does not regenerate, and you just have to learn to adapt to these things. This has all been turned on its ear over the last several years, easily over the last 20 years, and it's getting to be more and more in the consciousness of all healthcare professionals. So if you think about, we know skin turns over. We know that we get new skin cells, and we know that if we just wipe our hands, we've lost thousands of skin cells that are tiny. We can't even see them because the cells are so small. You know that if you have some dry skin and you rough it up a little bit, all these skin cells just slough off. You can see those. But we're always turning over our skin. It used to be thought that your nervous system did not turn over new cells, but we now know for 100% sure they do. The nervous system births new nerve cells, but it's at a very slow rate. So your skin turns over very quickly. The nervous system is much, much slower. So you will constantly be getting new nerve cells, which gives you, for the rest of your life, the opportunity to be healing as those new nerve cells are trained to do what they need to do. So we don't usually use the word permanent. Now we use the word chronic. So it's usually after 6 months a person is considered to have a chronic injury. Now, it used to be that researchers or that medical professionals would say you have 2 years, and at that mark, what you have is what you have. But we know now because of neuroplasticity that is not true. And the reason why the 2-year mark was delineated is because that was as long as people studied individuals with spinal cord injury. So somewhere along the line, people were studying, looking for return of function for individuals with spinal cord injury, and they really didn't notice much after going on after the 2-year mark. So they said, well, that's it, and that's as long as we're going to look. But now people are looking longer. Research has certainly taken a different look, and there's a lot more long-term studies that are going on. And so people are looking much, much longer at individuals and their return of function. So some people are years, and all of a sudden they have some kind of little movement in a finger or a toe or maybe an ankle. Something suddenly moves. And a lot of people will say, oh, well, that's an oddity, good for you, but that's it. Well, now we'll take that little bit of movement and harness it, work with it, and try to get more and more movement. So now any kind of little movement that you might have, rehabilitation professionals are taking that movement and harnessing it and really using it to the patient's advantage. So technically, in terminology and diagnostic terminology, at 6 months you're considered to have, instead of a new injury or an acute injury, you're considered to have a chronic injury. But even at the 2-year mark, it is not time to give up and say, well, this is it, because for the rest of your life, you will still be getting new nerve cells, and you will still be having the opportunity for return of function. I think there's a couple of things that happen after a while is after a number of years, people get tired. They've been exercising, they've been doing their programs, they've been doing everything what they should be doing, and they haven't had the lightning bolt sudden cure. Maybe they haven't been in a place where they have been looking for any kind of cure to come or any kind of return of function to occur. And so people stop looking for it. I see people coming to the clinic all the time that are in wheelchairs, that have their arms secured down onto armrests. They're strapped in. They have no opportunity to even try to move their extremities, or nor do they even think about it. Well, I haven't been able to move for so many years, so why even try to do that? And that's kind of their attitude. But once we kind of release them from all this bondage that they're in, I sometimes think they're like mummies inside some of this. Now, sometimes you need some support to help you sit up, or your arms falling off the tray. You might need some kind of strap or something to help if you're having tone and you're choosing not to adjust that in any other way. So you might need some kind of support to help yourself. But every day in the morning when you get up, and every day before you go to bed, just go through your whole body and think, toes move, my toes are moving, and see if you can get any kind of movement out of your body. Think about your ankle moving. Work up your whole body in your joints. As you're doing your range of motion exercises, think about when you're rotating your ankle, think about moving your ankle and what that would feel like. It's very beneficial. It makes you feel good when you're moving your body parts. If you're moving them actively because you can move your ankle on your own, or if you're moving your ankle by using your hands, or if somebody else is rotating your ankle, it's very beneficial to move your body and get that movement into your nerves and muscles. So at the 2-year mark, I would not give up. I would never give up, but still keep thinking about how you're going to strengthen yourself. Look for opportunities. There are more and more opportunities that are becoming available. It's been a struggle, and I realize this because I see it every day in my own patient population, where people want to participate in some of the advanced therapies or want to do any kind of treatment for themselves that they can possibly do, and yet their payer says, well, we cannot pay for that for you. There are treatments that have been documented that are effective, and still payers will say, well, that's in research, when clearly it is not. And so, I know as a person that's attempting to help people get some of these newer therapies, and they don't have to be even elaborate, just even to get some physical therapy or to use some aquatic therapy. And for people who don't have the resources that are able to go out and get these therapies and pay privately, it can be quite a challenge to be able to get some of these, and not always does it work. But if you look around, if you enlist some resources and get people to help you, even just to do range of motion, that's going to help benefit your body immensely. So be sure and think about anything that you can do, because the answer is out there. We just are still working towards it, but we want to be prepared for when the answer is definitive and it becomes a little bit more simple than the complexity of our healthcare system. So keep thinking about that, and keep walking and keep doing what you're doing to help try to make yourself functionally, to gain some functional improvements, because it does come, but it's very, very, very slow. The next question is a question about complications with the pacemaker that achieves bowel and bladder control. There is a little device that's a surgical implant. It looks like a pacemaker, but it's not really a pacemaker. A pacemaker is one of those devices that make your heart function at a regular rate and rhythm. As long as that pacemaker is connected to the heart, it will keep the heart beating. The device that goes in for bowel and bladder control is about the size of a pacemaker, and it can be regulated by the user. It's an implant that's surgically implanted, So there's an electrode that goes into the spinal cord, and then there's a little tunnel that tunnels around. And in the abdomen, there's a little device that's worn that is implanted under the skin in the abdomen, which the user then can control to stimulate the nerves for the bowel and bladder to hyperactivate through the use of this device. And it's an electrical stimulation that stimulates those nerves to go into hyperdrive and can open the sphincter so that your bladder can empty, or it can evacuate the bowel. And some of them for men can be programmed so that you can maintain an erection. Now, sometimes, it's individually how many nerves can be activated in your lower spinal cord, and there's a lot of evaluation that goes on with these devices before the implant to make sure that they're going to be effective for you. So if you decide that you would want to have one, the very first thing to know is that, yes, you are going to have surgery, and there are complications with any surgery that can occur. It doesn't mean they will occur, but it could possibly occur. So in surgery, you can always have bleeding. You could have a clot. That's any surgery on earth. You could have problems waking from the anesthesia. In this particular case, you could have issues because this electrodes are being applied to the spinal cord, to some of the nerves, that you could have more damage to the spinal cord than you had previously should something untoward happen. Also, with people who have paralysis, need to think about ventilatory issues in getting off the ventilator. You have surgery, general anesthesia, you are put temporarily on mechanical ventilation. And so if you have that, will you be able to easily be able to get off that ventilatory support? Because ventilation has a lot to do with the diaphragm, but it also has to do with the muscles in between the ribs and the abdominal muscles. So if you have dysfunction in any of those areas, and if you're getting one of these systems for bowel and bladder, you probably have some abdominal dysfunction as well. So, talking to your doctor and asking about particular complications because you're having surgery with a paralysis injury or disease to begin with, you need to really address those issues. The other thing is your postoperative care. If you have to be managed in the hospital for any particular point in time, you'll really want somebody to be with you. You'll want somebody to be supervising your care, because even though nurses and physicians and surgeons and respiratory therapists and all kinds of people will be taking care of you, a lot of people don't have the information that they really need to know about taking care of somebody with a spinal cord injury, because they never see people with spinal cord injury. It's actually a very rare occurrence, and so making sure that you are well cared for after the procedure is going to be key. Talking about autonomic dysreflexia, if you have any episodes of dysreflexia, or might you be getting some after you have this kind of surgery, during the healing process, that kind of thing. Looking at pressure ulcers and skin care, and making sure that everything is in line, that you're in good stead, just from having an elective medical procedure. Now, the other thing about the device itself is complications with that device. And of course, with anything, there can be complications. Whenever you have an implant, these are made specially so that they are not going to upset anything within your body, but sometimes people can have reaction to having a foreign body within their system. The electrodes can be misplaced or can become dislodged. The pacemaker battery will have to be changed periodically, and since that's implanted under the skin in the abdomen, that's another small procedure to open that up to change the battery. Adjustment might take some time in getting the correct adjustment. People that put these in are experienced in putting these in very rarely do you get, will you be the first patient of a surgeon that has one. They are usually trained with somebody else, and so they're really efficient and they know exactly what they're doing. But even with that, they're making an educated guess about how much stimulation your bowel and bladder will need. So sometimes these have to be adjusted up and down to achieve effective bowel and bladder control. There is a period of time where you have to wait before you can engage in the device, with the device. And so sometimes all these kind of thoughts don't really, people don't really think about. Of course, the chance of having an infection or getting a DVT or a blood clot or a pulmonary embolus with any kind of surgery is always a risk. So these are all the kinds of things that you need to think about. So you just need to talk to the surgeon that's doing it. If you have the opportunity to speak with somebody who has one, that you can kind of get the nuances of using these, that's always a nice thing. If you have more questions and you're not really sure about the device, you can always call this peer support group at the Christopher and Dana Reeve Paralysis Foundation, and they will find someone who has one that you can connect with and talk to a person who's had it for a while, see what's going on with everything with them and how they dealt with some of the issues. So those are all really good opportunities. Some people, most people that I know that have had these have enjoyed having them. I haven't really, in my own personal career, I haven't come across people who haven't enjoyed them that much. The thing that I guess I hear, not really that often, but the one thing that I hear is that sometimes they don't have the magic fix that people dream that they have. I think that sometimes people get these devices and they think that it will be like it was before their injury or their disease, and that their body will just function, just automatically or something. And it's still a device that has to take some control, and you still need some planning. Especially if you have no sensation, you still have to do some time toileting. So it's not like you can, like go 12 hours and not empty your bladder because you didn't feel that you needed to empty your bladder. So I think sometimes people have maybe a bigger concept of what this is going to be than what it actually turns out to be. So you still have some limitations in that you still have to, empty your bladder every so many hours. You still have to empty your bowel. And, sometimes I think people, kind of think it's going to be more than what it is. Although most people really seem to enjoy having them and find a lot more freedom than they had before. So I'll leave it at that. So the next question is, can you explain why I'm always cold and what can I make it less extreme? This is such a great question. It really fits in with our autonomic discussion from the autonomic nervous system. People who have spinal cord injury tend to be colder. They have less body heat than people who do not have a spinal cord injury. Again, some of this is because of movement, but because movement generates heat in our body. If you think about exercising and working out, people get very warm, hot, and sweaty because they are generating all this energy from inside their body. When you have paralysis, you're not moving your entire body as you were before. It's very difficult to really get a cardiac workout, which really generates a lot of heat when your heart speeds up. But also, a lot of that is because the autonomic nervous system is not engaging. So when you're cold all the time, you're more in that rest and digest stage, so that the autonomic nervous system isn't coming up with that hurry up and let's speed up the body. If you don't have a spinal cord injury and you go out and you get chilled, your body feels that as a threat, and so your sympathetic nervous system is going to speed up and get that heart pumping faster to help warm your body. So if you don't have that ability, what happens is that your body tends to become cold, or your body will tend to become more closer to the temperature of the room you're in. So you might be cold if you're in a cold environment. If you get in a very warm environment and you're outside and it's really hot or the heat's too high, you're sitting too close to the heater blower in your home and the furnace is on and you're getting too warm, it's because your body can't really, the autonomic nervous system is not adjusting to the too much cold or the too much heat. Now, by far, people tend to feel too much cold because they're not able to generate heat through movement, so their body's not, the sympathetic nervous system isn't speeding up when it gets cold. So what can you do to make it less extreme? Well, the first thing to do is it sounds oversimplified, but the first thing to do is address for the temperature. So even if you don't feel the cold, your body's still going to react to the cold. It's still going to feel cold. So I see a lot of people that are out at football games. They're in chairs. They appear to have a spinal cord injury, and yet they don't have shoes and socks on. They're like, oh, my feet never get cold because I don't feel that, so it doesn't matter. And their little toes are turning blue because they're so cold. So your body is still going to be sensitive to cold. It's also going to be sensitive to heat. Something that's really good to do is exercise. And how do you exercise? Do those range of motions. Do your exercises. Do your wheelchair push-ups. This is going to stimulate your body. It's going to stimulate your body to get that blood flowing and get moving. Something that you do not want to do, you want to put on layers of clothes. You do want to do this. You do want to put on layers of clothes so that the air can trap between the layers, which will insulate you and keep you warmer. What you do not want to do is to get an electric blanket or to get some kind of electrical heating device that if you get overheated, you could get burned and you wouldn't know it. So avoid that, but use more natural kinds of remedies. If you're cold, try to sit closer to the furnace vent, or if you have a fireplace, you might want to sit closer to the fireplace, but not so close that, how when you sit next to a fireplace, one side of your body gets extremely hot and the other side of your body is extremely cold. So try to keep things even. Don't get so in this hot world that you think, oh, this is really going to help, because it's that autonomic system that's not working. So the more you get overheated, the less chance you have of getting that internal autonomic nervous system to turn on to cool you off or to heat you up. If you get in that cold chill and you just cannot get out of it, it seems like the way that your autonomic nervous system resets is to sleep. And when you sleep, your brain calms down, everything calms down, it goes into this rest and relax. But your body will start to warm up. So be sure and keep yourself, if you're always cold, be sure and keep yourself warm and bundle up in layers. Move your body around if you're feeling a chill. Move your body around, do some wheelchair push-ups to build up a little heat and energy. If you can't do a wheelchair push-up and your chair has a tilt and recline on it, tilt and recline a couple of times, and you'll be surprised when that chill is starting to come on, how much that will help you, because your body's moving around, and so that stimulates that nervous system to get working. Now the next question is air travel cushions. Oh gosh, yes. This person can't tolerate airplane seats. No, if you need protective cushioning for your skin, an airplane seat will not do it. It has a lot of cushion, but it doesn't have the right kind of cushion. It has a dense cushion, which will cushion you a little bit, but what happens is where your bony prominences are, that airplane seat will act as a constrictor around where the bones are pushing in there. It doesn't disperse the pressure of those bones and of your bottom or your back, because the backs are padded also, but they don't disperse and make the pressure evenly around it. So this person has a Rojo cushion, and that's what I tell people to do, is to use their wheelchair seating cushion. Be sure and take that on the plane with you so that you're at least seated on the proper cushion so that you don't have problems. You still need to do those wheelchair push-ups and relieve that pressure. No matter what cushion you have, even if it's pressure dispersing, you still need to move around and change your pressure. People who don't have an injury tolerate these seats. Well, actually, I don't think anybody really tolerates an airplane seat. They're not that comfortable. But people will, because they'll move thousands of times every hour with just little micro adjustments. People are always moving. When you have a spinal cord injury, you're not moving so much, so you don't get those little bitty changes in pressure. So you still, even if you're using a Rojo or you're using some other kind of pressure dispersing cushion, you are not going to be able to get that pressure moved around. So you need to do those releases. Now, when you put the Rojo or you put your cushion on the airplane seat, one of the problems is that the airplane seats have lumbar support. They're designed to help support people's bodies. Now when you've put that cushion on there, you're several inches off center. So your body's pushed up several inches because you're on the cushion. So you don't align with the natural form of the airplane seat. So if you can get something for your back, or if you have a back cushion, you would want to use that as well. You can try adjusting the seat. The people behind you won't like it. If the minute somebody pushes their seat back, it's like whoever's behind you is like, oh, thank you, because they're also scrunched in there together. So if you can get in a place where there's a little bit wider area, that's a little bit helpful, but taking your cushion with you on the airplane is very important. And then if you have any kind of cushioning that you can use on your back to kind of help readjust the back of that seat. So it's kind of a combination thing. One is that the seat isn't regulated for you, and then that the cushion isn't regulated for your needs. And the other thing is, once you use your own personal cushion, it makes the back off kilter. So it is a real challenge, I will tell you that. It would be wonderful if they would make airplanes like, buses or vans where you just roll your seat on and lock it in, and then everything would be tailored specifically to your needs. So it is challenging. There's a lot of challenges in flying, and I hope that doesn't stop people, but anything that you can do that can match up more to your needs, the better. But you do need to sit on your own cushion and adjust the back accordingly so that it becomes more comfortable to you. I think we have time for one more question. We have so many, so I would really like to get more of these. But maybe we might have to save some to next time. My husband broke his femur 2 years ago. It's still not healed. Okay, so what happens after spinal cord injury, again, through the autonomic nervous system? How about that? One of the things that's happening is when you stand on your bones, that's what makes them stronger. And so when you're not standing, your bones tend to get very osteoporotic, or you can even get osteoporosis. And sometimes what happens when the bones get so thin, this is why we recommend everybody have bone density tests every year, because your bones can become very thin, with osteoporosis, and then sometimes just a little movement, or you're doing your exercise and the bone snaps, or you have a fall, and then you're in a real pickle, because when the bone is that thin, there's really no place to put it back together again. So if you have that real thin spot in your bone, usually what they'll do is, if you have a bone break, they will put a plate in there, and they'll join the one end of the bone to the other end of the bone to hold it together so that the bone will grow back together again. And then the bone has what's formed on it around the broken place is called a callus, like you would get on your foot or your elbow or your hand. But it's inside and it's on your bone, so it kind of makes a thick bone overgrowth right where that fracture was so that it doesn't happen again. But if you have osteoporosis, there's no place to put that plate to attach because the bone is still too weak to attach a plate on either side. So what you probably will need to do is have that bone density test, see what your bones are like, work with your orthopedic doctor to see if he can take medication to help build his bones, and then work through this process. It can take a long time to get that fracture to heal, and so you might have to wear a splint or something to support externally that area so that there's not more damage that occurs. So work with those orthopedic doctors to see if his bone density is where it should be, and then what they can do to help build that up over time. And so that's what's been going on with that. So the next question is about a person who's having terrible pain in their left hip. So they're doing everything, they've had treatments, but they just nothing seems to be able to help them with this left pain in the hip. So a couple of things, just real quickly, is to make sure that the pain is coming from the hip and not referred from someplace else, like in the bowel or in the lower abdomen. If there's a bowel impaction or diverticulitis or something that's happening inside that body, or in the groin if there's a blood clot. You've had x-rays and C scans of the hip, but what about the surrounding areas? So I would ask about that. I see this person's tried lots of different things, and let me say, there is just nothing worse than living in this terrible pain. It is exhausting, it is frustrating, and pain is such a hard thing to treat because it is so unique to everyone. Some of the things that could be caused from that is if you have a spinal cord injury specialist, you might want to talk to them and see if they're having some neuropathic pain from that area, which would be treated differently than it sounds like what they're being treated for is joint muscular pain. If it's neuropathic pain, it's going to require some different treatments. There are medications. I noticed that in your things that you have tried that there's no medications listed, well, steroid injections, but no oral medications. And, some people do not want to do that because oral medications work systemically throughout the whole body. And so it doesn't just go to the place of the pain, but they work throughout your whole body, and some people don't want the side effects of that. And so I get that loud and clear. Another thing that you might want to try if you're just trying to work in that one location would be to ask if you could try like a lidocaine patch to see, and you need to talk to your doctor about this to see if it's appropriate for you. I only have this one little line about your condition, so I don't know enough to say do this or don't do this because I don't know that much about you, but I can offer suggestions that you can talk to your doctor about. And something you might want to try is a lidocaine patch to see if that affects the pain. And if it does or if it doesn't, at least you'll have a little bit more information about what kind of pain it might be, or if it's coming from that exact area, or if it's being referred from someplace else. So that's just kind of one thing, one little strategy that sometimes people use. You can go on with different kinds of treatments and assessments and see maybe through an EMG or nerve conduction study if they can isolate where that pain is originating. So that might be helpful. But those are just a couple of things to try. So I think we are unfortunately at the top of the hour. Oh, well, there's just one more thing. I just can't stop. I'm sorry, but I know I have
Thank you,
to.
Linda. Go ahead.
Well, the mitral fan-off surgery, that is somebody who's thinking about doing that, and it's a female name. And so this has been, again, it's surgery. So, you know, all those things that I said about surgery, know that. But it's been wonderful for especially women who access to the urethra for doing the catheterization is very difficult. And if you are leading a very full and busy life, you can't always be, you know, going to your bed to get the catheter kit out, you know. So using the micro fan-off has been helpful, but there again, I want to say it's not the end-all, be-all. You're still catheterizing, you know, you still have chances of infection and all those kind of things. This person also had AD, so this makes it a little bit easier to get to that area and to help control your bladder, especially if you're a female. Sometimes men use it too, but it's a little bit different. The procedure is the same, but men don't use it as much as women because they have a penis, which makes access to the urethra much, much easier than the anatomy of the female, which is far more difficult. So I apologize. But anyway, I hope that's of some help, and if you want to talk further about that on the blog, that would be just great. Just go ahead and we'll make that a blog issue. So thank you very much for listening in today. It's always wonderful. The time zooms by for me. I hope that it is not too much of a struggle for you guys to listen. I hope it's helpful. If you have any questions or any issues, please just write into the blog, and otherwise I'll see you next month.
Thanks a lot, Nurse Linda. And everybody, as a reminder, can go on our online press community at christopherreeve.org/nurse and leave your questions there for her if we didn't get a chance to answer them today. So thanks a lot for joining us, and we'll see you or hear you on the call next month.
Thanks, everyone.
Bye.
Ladies and gentlemen, that does conclude the webinar call for today. We thank you for your participation and ask that you please disconnect your line.